My predecessors, Dr. Deepak Mishra, Dr. Bharat Jasani, and Dr. Rajiv Kaushal, have made my job easier. At the outset, I would like to thank Dr. Anuradha ma'am and the lung cancer, the year-end review for giving me this opportunity. I represent Datar Cancer Genetics. To start off, I would not take much of the time for introduction because it has been beautifully elaborated by my colleague here. So as we all know, non-small cell lung cancer, we need to know the morphologic molecular characterization of tumor, predictors of response to therapy, ascertain the prognosis, and we need to also have knowledge of targeted or immunotherapies based on specific genetic alterations. And some of these slides might really look, I don't know why it is not moving. Just a second, please. So we have seen that earlier on, it was a morphologic classification. Now we have the molecular subtypes, and it's very important for any lab to look at all of these, understand the pathologists need to be an essential part, which has been nicely elaborated again. I won't touch upon much of this laboratory workup. Suffice it to say that NCCN guidelines and other guidelines now recommend a broad molecular profile. Each of these genes will be looking at differently in terms of what are the requirements, what are the best platforms that are available. But my talk essentially would comprise of the molecular stratification on NGS. So these are the different types of samples that we come across. They might be small core needle biopsies, dissected specimen of lung, cell blocks. They could be FNAC smears, cytospond material, EBUS guided cytology material. As Dr. Rajiv said, ROSE is ideal. And there could be pleural fluids, peritoneal fluid. And of course, for the liquid biopsies, plasma is what is most used. Judicious use of tissue, I don't want to go again. So single gene assays versus comprehensive molecular profiling. We know that the comprehensive molecular profiling is now preferred because the PCR based assays would look at specified targets and we would not know the unknown targets. And with so many actionable targets that have been identified in recent times, it becomes pertinent to understand that a comprehensive molecular profiling has been recommended by all guidelines wherever feasible. Despite that, my colleagues have discussed all the challenges. And so why NGS? We can detect multiple targets and multiple genes in multiple patients simultaneously. So therefore, it gives us tissue optimization, makes it cost efficient because you're doing everything in one go. And obviously, now the technology has so much evolved that the turnaround times are also shorter and we're getting quick results from NGS. So these are the different genetic aberrations which we would be seeing: single nucleotide variants, insertions, deletions, copy number variants, and complex genomic rearrangements. So these are the latest NCCN guidelines which highlight the importance of comprehensive molecular profiling. Wherever feasible, if you could look at a broad-based panel is recommended by NGS. And for fusions, RNA-based NGS is recommended wherever feasible. So these are the different steps of NGS. So you have to ascertain whether you're looking at a targeted sequencing, whole exome or whole genome sequence, and then the nucleic acid extraction, library generation, DNA fragmentation, template generation, sequencing. So each of these processes is highly governed by quality measures. So quality is an essential component, and therefore the NCCN guidelines mandate appropriate accreditations. They say CLIA, but it depends on the country. So we have our NABL. So these are the quality measures that have been taken, and these labs need to participate in the external quality assurance schemes as well. Data analysis is another important aspect of NGS. Sample collection and preservation. We know for somatic testing, generally it is the tissue. We can of course do it on the liquid biopsies as well, and for germline testing we use the EDTA blood. Now just to highlight the basic terminology, might sound very preliminary, but for the benefit of novice or postgraduates here, the single nucleotide variants are variation in a single nucleotide And insertions are a single nucleotide which is inserted into the DNA, which makes it longer. Deletion, when a single nucleotide is deleted. Translocation, when a piece of chromosome is swapped with another chromosome. Inversion, when a sequence change where compared to a reference sequence where more than one nucleotide is affected. And the fusions, of course, are hybrid genes formed from two previously independent genes. The copy number variations are commonly called the CNVs, may be comprising of segmental duplications, complex CNVs, or deletions. So these are common terminology that we get to see in the NGS report. We need not be bogged down by these terminologies, but as we understand this, it makes the job easier. Variant allele frequency is a fraction of alleles in a sample that contain the variant. Coverage describes a relation between the sequence reads and the reference genome. So these two aspects are very important before you decide, even if you are doing in-house, for validating your assays, or whether even if you are outsourcing, you need to know what is the coverage and the depth of sequencing. In interest of time, I will not discuss all these, but if you can see, this is a recent paper which shows that there is an ever increasing targets which are being now worked upon by the different pharmaceutical companies to find out appropriate drugs, and the predominant one, as Dr. Deepak Mishra said, were the KRAS and EGFR. Now, just to reiterate what has already been discussed, I will not touch upon EGFR since Sir has already covered it extensively. Suffice it to say that in a resistance setting, we get to see EGFR T790 mutation, which is the most common mechanism of resistance, but it is not that, it is not described at the time of diagnosis. So if T790 mutation is seen at primary diagnosis, then genetic counseling needs to be done and germline testing is needed. So that is the only alert apart from the standard recommendations that has been given by NCCN. Now just to give a pictorial, so this has three domains. When the ligand comes and binds, there is normal cell growth, proliferation and differentiation, but when there is a mutation in the tyrosine kinase domain, there is constitutive activation leading to proliferation, invasion, angiogenesis, metastasis, and inhibition of apoptosis. This I would not cover, Sir has covered. Exon 18, 19, 20, 21 are the mutations that are the exons that show mutations. This is exon 20 insertion. Just to say that specific sequence of EGFR exon 20 insertion to be specified. So many labs just do the sequencing and say that insertion is positive, the sequence is not given, but that is very important because most have lack of response to therapy except the FQEA and LQEA. So it's important to identify the sequence of EGFR exon 20 insertion. Now moving on, what are the NCCN guidelines as far as EGFR? The new recommendations are that even in the adjuvant setting, when the surgery has been done, molecular testing for EGFR mutation is recommended to determine the adjuvant after the ADAURA trial to recommend for adjuvant treatment decisions. Now, ALK, as we all know, the most common is the EML4 ALK. The other fusions and mutations have also been detected, but this is commoner. What we commonly use is by IHC, which is easy. FISH also is the gold standard, but with NGS, we are getting to see the mutations and fusions, and therefore, that is what is recommended. And what has been observed in our country is that the ALK fusion is, the frequency of ALK fusion in the Asian counterparts are higher, as has been seen in several papers from Tata Memorial, from our institute, my former institute, Basavatarkam Indo-American, and Rajiv Gandhi, and many others who have seen ALK to be higher than the standard 3 to 5% positivity. Moving on to ROS, again this is a fusion. The fusion partners could be several. I would not elaborate. Commoner ones are the CD74 and SLC34A2. And ROS1 is generally done by FISH. IHC is not recommended. It's only used for screening. And now with NGS, it is covered with the RNA sequencing. Please remember all fusions by RNA sequencing wherever possible. So ROS1 is encoded by the CROS oncogene. The KRAS G protein, which is now very important because of the new FDA approval. The KRAS protein is a GTPase that functions as a molecular switch between GTP bound form to inactive GDP form, and in oncogenic or when there is a mutation, this process is disrupted and the RAS remains activated and therefore leads to the RAF-MET pathway activation, leading to proliferation, apoptosis, differentiation, and angiogenesis. So sotorasib and adagrasib have now been approved, and therefore KRAS mutation also has become an essential component of the broad molecular profiling. Moving on to BRAF, V600E is seen in 1 to 2%, it's seen in 3 to 4% of NSCLCs, and V600E is seen in 1 to 2%. Now this is also recommended by NGS. DNA sequencing would suffice, but we all know that there is an antibody, but this is largely used in thyroid cancers and needs extensive validation if you have to do it on the lung cancers. So this has a drug as well. So dabrafenib is the drug which is, so that's why BRAF has also been included. Now moving on to MET aberrations, which is the common form of resistance again. MET aberrations that are seen commonly are the single nucleotide variants. More common is, which is now has a target, is the exon 14 skipping mutation, and we also get to see amplifications and fusions. So there are different types of MET exon 14 skipping mutation. So the commonest one, so I would not go into the details of the splicing mutation. Suffice it to say that 13 and 15 would fuse if there is a whole exon deletion, that is of the exon 14. And where that happens, the mutation happens, has also been studied extensively. Just suffice it to say that it's commonest in the donor site. So if you could see at the terminal end of the exon 14, that is where the mutation happens. And these are seen of, these have been reported 2% in adenocarcinomas, 1% in squamous cell carcinomas, 6% in adenosquamous carcinomas, and 13% in pulmonary sarcomatoid carcinomas. In our cohort of about 198 cases over the last 6 months, we have seen 6%. So it is too early to say what is the frequency of MET exon 14 skipping mutation, but these are largely seen in elderly age group and carry a worse prognosis. But the good part is that you have a target for this, and RNA sequencing is the key. So it is very important that your assay has both DNA and RNA, especially when you're looking at these fusions. So it depends on how your lab has validated. If you do it sequentially, probably you lose out a little bit on the turnaround times. But if you do it upfront, both DNA and RNA sequencing, it does cost a little bit more, but you get everything in one go and the turnaround time is significantly shortened. So these are the differences between a DNA sequencing and RNA sequencing. It becomes very easy by RNA sequencing because you are able to look at directly the protein expression, because there is in DNA sequencing you have to do the intronic tiling and things like that, which may miss the MET exon 14 skipping mutation. Therefore, it's recommended that RNA sequencing has to be done essentially before you call it negative. NTRK1 also was a recent entrant. It is a tyrosine kinase receptor kinases that are rarely rearranged in NSCLC, but these are very important because again they have targets. So larotrectinib is a good target for NSCLCs harboring NTRK1, 2, 3. So what is recommended, of course, is RNA sequencing if you have the NGS. Otherwise, FISH and IHC become cumbersome because they not cover all the 3 variants. So DNA based sequencing may underdetect NTRK1 and 3, and therefore RNA sequencing again is recommended for NTRK. So this is just highlighting the importance of RNA sequencing if you look at the latest NCCN guidelines. So this is just to show what are all the fusions that will be picked up on the RNA sequencing. Now acquired resistance mechanisms, as we all know, the commonest one is T790, EGFR T790M mutation, but we also get to see the MET amplification, and this is now listed in the emerging markers along with HER2 on the NCCN guidelines. Hepatocyte growth factor overexpression is also said to be one of the forms of acquired resistance. So these are the current recommendations for. You need to have EGFR mutation, ALK rearrangement testing, ROS1, BRAF, NTRK, RET, and MET exon 14, because all of these have targets. And of course, I have spoken about the progression. Just a brief this thing about the ctDNA, the circulating tumor DNA or liquid biopsy. Different technologies that are available are RT-PCR, droplet digital, and the next-gen sequencing. Now, it shows that limits of detection are much lower for NGS, and therefore the pickup rate is higher. It is nearly 0.01 to 5% as opposed to real-time PCR 1 to 5%, which is not recommended, and for liquid biopsy. And of course, droplet digital, it only hits the target, so that way it has good low limit of detection. You can pick up if you know the target, but if you do not know, probably you will again have to resort to NGS. These are the definitions. As we all know, liquid biopsy is a broad category for a minimally invasive test in a sample of blood to look for circulating cancer cells or fragments of tumor-derived DNA or RNA. And we need to know that the circulating tumor DNA is found in the bloodstream, refers to DNA that comes from cancerous cells. It's a component of cfDNA secondary to either apoptosis, necrosis, or secretion. Now, we have to differentiate between cell-free DNA, which includes the normal DNA and tumor DNA, as opposed to circulating tumor DNA, which is specifically coming from the from the tumor. So, it is very important you look at the circulating tumor DNA component rather than the cell-free DNA, which also includes the DNA coming from WBC and other cells, non-tumorous DNA. So, this is just a pictorial diagram. And liquid biopsy also has the advantage that it addresses tumoral and temporal heterogeneity. When I say that if you are sampling a tissue, so you're looking at only a small part of the tissue which would have a different kind of alteration as compared to the adjacent focus. So liquid biopsy addresses that because it is a single snapshot of a particular tumor. It could be primary, it could be metastatic. And also temporal heterogeneity. So along the course of the treatment, you have a baseline and thereafter follow-up also can be addressed by liquid biopsy, and that's the advantage. But the disadvantage is when it is negative, you have to follow it up with a tissue sequencing. And therefore, the challenge is low presence of circulating DNA, especially in early cases, and therefore cell-free DNA, that is a total nucleic acid, which includes DNA and RNA, are recommended. CHIP is one thing which we have to be wary about when we are handling liquid biopsies. CHIP is nothing but clonal hematopoiesis of indeterminate potential. We know that approximately 50,000 to 2 lakhs hematopoietic stem cells in an adult produce an estimated 10 to the power of 10 progeny blood cells every day. So after repeated cell divisions, these cells accumulate these acquired somatic mutations. So just to explain in simple terms, during childhood, we do not have any mutations. But as we grow, we start having these passenger mutations which are not harmful. And as we age, that is after 55, 60, we start to see these mutations, these somatic mutations, which might be confused with circulating tumor DNA when we are doing an assessment on the liquid biopsy. So our filtering approaches on NGS should exclude these germline mutations associated with clonal hematopoiesis. So this is a very important factor we need to be cognizant about when we are talking of liquid biopsies.
Dr. Murthy, I'm sorry to interrupt. Can we please wind up in next couple of minutes?
Sure. Another thing is the transformation during treatment to small cell carcinoma. And we all know that this cannot be picked up on liquid biopsy. So again, we need to be aware of this. And TP53 and RB1 mutant lung cancers are at unique risk of histologic transformation. When we see this upfront, we have to be aware that this could lead to a small cell carcinoma transformation. So the key takeaways are, it is recommended that wherever feasible, you do a broad panel of molecular testing in NSCLC patients, RNA sequencing for fusion testing wherever required. Liquid biopsy is a useful complementary tool with tumor testing if no mutations are identified or negative, and tumor tissue sequencing still remains the gold standard. Suboptimal or variable practices in collection, handling, and processing of tissues can lead to significant variability in molecular and proteomic profiling, and multidisciplinary communication is always needed. So decisions are based on availability of representative tumor tissue, urgency of test results, and accessibility of tumor sites. So I'd skip this in the interest of time. Turnaround time and quality are the key to successful NGS. Thank you so much for a patient hearing.
Thank you, Dr. Murthy, for a very nice talk. So
Thank you.
now, before proceeding to the next session, we will have some questions discussed for each of the talk earlier. To begin with, first question is for Dr. Rajiv Kaushal regarding the tissue is an issue talk. Question is that good quality DNA RNA is difficult to obtain from FFP blocks. What is your comment regarding the DNA RNA quality from older blocks? And is there any way we can improve the quality from the old blocks, specifically for genomic application?
Yeah, so that is the very common problem which we especially face in India because the archival of these blocks are not done as per the standard recommendations. So, if we have to preserve, do the good molecular workup on the old block, the material should be archived in a proper ambient condition. So the air conditioning of the room as well as the temperature. So that is very important, especially even in Mumbai we face a problem because it is the environment is quite hot as well as humid. So both these conditions deteriorate the DNA. Sometimes the fungus grows on the blocks. So the only way to surpass this problem is to have a good proper archival facility. So that is the only solution for a long term. So we do also sometimes face this issue because the blocks are not properly stored.
Okay. Thank you for the answer. The next question is for Dr. Bharat Jasani. The question is regarding PDL1 status in lung cancer. EGFR and ALK positive tumors are receiving good benefits from TKI. However, PDL1 status in these oncogene driven tumors is often detected in few of the cancer cases. So, what is the value of that, and how do you suggest the therapeutic regimen should be adapted in such cases?
Yeah, I must say I have to plead ignorance here in this very specific area because I'm not involved in the overlapping role of molecular pathology and PDL1 analysis. So I won't be able to give an answer, I'm afraid, which makes any sense. So I'll have to excuse myself for that question. Okay.
Okay, thank you, sir. There is one more question in the chat box by Dr. Rajiv Kaushal regarding CPS scoring status. So, what is your comment on CPS scoring for lung cancer applications, and why this is not yet recommended as a standard option?
That's a very good question. This is a bit of an enigma. Of all the other cancers, CPS seems to have become a standard now as a final biomarker strategy for determining whether the cancer can be treated or not treated with immuno-oncological means. For lung cancer, this remains an enigma in the sense that the studies have been done. I've asked the questions directly to MSD people, and they say that so far they haven't found any evidence of immune cells playing any role in the actual progression of the cancer with regard to PD-L1 expression. So this may be a kind of mystery we need to resolve. But so far, that's the answer I can give you, that it remains outside the usual thinking process of using CPS as the main marker. Okay.
Okay. Thank you, sir. We have one more question for Dr. Deepak Misra. The question is that how different mutations in exon 20 affects therapeutic response. You have shown quite many of those, and there are two different classes that are known. One is point mutation, and another is exon 20 insertion mutations. So, do they have different kind of therapeutic response, or do they have any other kind of strategy which we can use to tailor the therapeutic option?
You see, normally the duplication mutations are not that bad, but the insertion mutations. So point mutations are good, but the other ones are not so good for the first and second line TKIs. They normally become resistant in about a couple of months. Usually the DEL19 and the L858R goes on for about a year or so before they develop resistance. So unlike the exon 20 insertion mutation, about 3-4 months they become resistant to first, second line, and they need switching over to the third line and other agents. So that is the reason why del9 insertion 20 mutation has become important. Yes, there are certain small cohort of patients of del of insertion 20 mutation which are relatively better, like the point mutation ones, but the other insertions are not so good as the point mutations. I have shown that actually in a hurry. I skipped many slides which are important from therapeutic point of view. So that is what it is. And the percentage of patients are so small, 5 to 10% in large series, but in our series, I don't know what is in Rajiv's series. But in our case, it is about 3%. Sudha must be having her own figures, and Rajiv must be having his own figures.
Sir, our positivity rate was also in the range of around 2 to 3%.
Yes.
But recently, I have come. There's some data has shown that as compared to the RT-PCR, for NGS is now being recommended, especially for exon 20
Yes.
mutation detection, because many mutation, even there's a data from where in the foundation one NGS data was compared with the conventional RT-PCR, and around 40% of the mutations on exon 20 was missed by the conventional RT-PCR.
Yes, possible. But Oncology
maybe,
focus
especially if we want to see the true prevalence of exon 20, we need to do more or more and more testing, even for EGFR by NGS.
Yes, possibly we are missing quite a few of them.
Okay, thank you, sir, for answering that. So
Yes,
we will proceed
yes,
with
sir.